So we're going to start today talking about diabetes, namely type 1 and type 2. What I've seen over the years, and especially once students get on clinical rotations, is they just seem to have a really hard time with diabetes. And it's not as bad as you think it is. And my thought was people just don't understand where it fits into the overarching place of medicine. What are the mechanisms behind what causes it? And they just kind of get jumbled all over the place, no matter how much we really talk about it. So I made this. This is a new lecture for this year, explaining how I think about diabetes and thinking about it in kind of a step-by-step fashion as a spectrum of metabolic disease rather than just a pure, you have diabetes or not. And when it comes to talking about diabetes, type 1 or type 2, a lot of the old ways of thinking about it and the general thought about it is the problem being with elevated blood sugar, okay? That's kind of the old way of thinking about it, and a lot of people kind of default to that when they think of diabetes when you truly don't understand it, which is fine. But then it makes us say, well, let's treat the high blood sugar then, not the underlying mechanisms that led to the elevated blood sugar. And the difference between type 1 and type 2 diabetes is whether there's less insulin being produced or no insulin being produced, or whether the insulin's being produced just fine, it's just the tissues have become resistant to insulin. Type 1 diabetes is actually a little bit more straightforward, where we get autoimmune destruction of the beta cells in the islets of Langerhans in the pancreas, and so the treatment's easy, insulin replacement. That's pretty much all they have. Type 2 diabetes is a little bit more convoluted, but the end results of both of these conditions, whether from type 1 or type 2, is the same. We get hyperglycemia and then eventual damage to what we call the 8-organ model of diabetes. You'll see that the major organs that will be discussed in other courses or throughout your career are going to focus on 3 main ones, which are the eyes, the kidney, and the neurons. But be mindful that similar damage is going to occur to the brain, heart, blood vessels, pancreas, feet, and skin, and basically every organ in your body. And so because I'm truly myself really passionate about diabetes, metabolic syndrome, obesity, and in an attempt to push my own ideologies, I've come up with my own definition of type 2 diabetes. I don't think of it as a sugar problem. I think of it as a chronic energy surplus problem. Remember, our diet can be generally broken down into 3 major energy molecules that we take in, which are glucose, fats, and proteins, or amino acids, same thing. But over time, that excess energy consumption is going to demand a lot of our metabolism. You know, it's only been in the last 100 years that humanity has had more food than not. All the time before that, human beings have been starved. We've been living in energy deficits. So the mechanisms and evolution have primed our bodies to live in starvation mode, not energy excess mode. So we don't have good mechanisms to handle too much energy. We only have it to handle not enough. And just like we've learned in the first lecture series, what happens when we chronically overactivate receptors with meds or whatever? They'll downregulate, right? Because they're like, whoa, these are being activated too much, let's downregulate them so we get homeostatic signaling that we had before. And they'll lose their potency. And insulin is one of our major mechanisms for glucose uptake into cells. And over time, with chronic energy surplus, those receptors are going to downregulate. Not only will they downregulate, we're going to have a lot of excess sugar and proteins and fats in our bloodstream. And over time, we got to do something with those. But those mediators can spark chronic inflammation. And eventually in type 2 diabetes, the pancreas can fail because of that. And so let's look at this kind of metabolic syndrome that is occurring and track it from start to finish so we can actually really understand what's going on. And we'll start with nutrient handling or nutrient intake, then the eventual endocrine disruption, then the eventual damage, and then the drugs that we'll use to augment this pathophysiology. And it'll make the drugs a lot easier to understand. And with nutrient handling, remember again that our food is going to be split down into those three basic molecules, all of which are going to enter the bloodstream from our GI tract and signal to the body that we now have a nutrient abundance. And our body now has to handle those different molecules. And not all nutrient molecules are going to have the same quality. I mean, I had a cosmic brownie for breakfast this morning. I should have probably had, I mean, it's not hard to say that probably an apple and a banana was probably a better choice than a cosmic brownie, but I have no control over myself. So not all nutrients have the same quality. A lower quality fat or sugar is going to be processed very differently than a higher quality one. And what determines the quality has to do mainly with its chemical structure, or how fast it's absorbed into the body, and then the signaling pathways that they'll produce. So the core issue with quality nutrients really doesn't have to do with the energy that it contains within it. It's how fast it's delivered, or whether it's delivered too often, or it's delivered in the wrong form. Let's start with carbs. Carbs are broken down into sugars, carbohydrates. Carbs are our sugars. And the quality of carb is really going to depend on how fast it's absorbed and delivered into the blood. So it all has to do with the speed of absorption. And we have two types, or two general types. I made these up, but not really. We have simple refined low fiber sugars like the monosaccharides, disaccharides, refined starches like in white bread or white rice, or sugary pop and soda and things like that. And then we have the complex, intact, fiber-containing oligosaccharides or polysaccharides, which are giant polymers of sugars combined together, which come from like vegetables or legumes or whole fruits or intact whole grains. And by the structure of these two things, these two kind of classes, you can probably see that these large, complex polymers are going to require enzymatic breakdown before they can become absorbed. They're acting almost like an extended release capsule of sugar compared to an immediate release version. So it doesn't hit the bloodstream all at once. Fiber is also really important because it slows digestion and absorption down too. Fiber is just a big fibrous mesh network of nutrient that we intake that doesn't get broken down. So it likes to combine with bunches of other things. And so the end result is a gradual glucose rise. And this will lower insulin demand and preserve insulin sensitivity. It just kind of makes sense. But those simple carbs don't need much breaking down to become absorbed. Their small structure kind of allows easy and quick passage across that gut lipid bilayer directly into the bloodstream all at once. And the result is a rapid intestinal absorption with a sharp glucose rise and a large amount of insulin release all at once. And this will promote things like hyperinsulinemia and beta cell stress. At the end of the day, all carbs are going to become glucose eventually. So this is why an apple behaves very differently than a cosmic brownie, right? Apples have lots of sugars and very complex carbs, whereas my cosmic brownie is just straight into the, might as well IV it right in the main. Even though the sugar content is technically similar. Fats are the oils of our body. Every neuron, cell membrane, lipid bilayer is going to be composed of fats, usually in the form of having a hydrophilic phosphate head with a glycerol and a lipophilic tail composed of saturated fat, one saturated fat and one unsaturated fat. Saturated fats mean that all of the carbons have been saturated with hydrogens, which forms a linear structure. An unsaturated fat means that the hydrogens were removed from some of the carbons, and those carbons formed a double bond between them, which kinks the structure, as we kind of see here. And this kink is only possible if that carbon-carbon double bond is in a cis formation. And we need a delicate balance of both of these, okay? You don't want to eat too much unsaturated. You don't want to eat too much saturated. You want a perfect mix, essentially. And that kink is very important because we find that most of the low-quality foods with low-quality fats are mainly composed of structures that form straight lines. And these are saturated fats and trans fats. Now, saturated fats, again, are not inherently bad, but remember, we need a balance of the kinked and non-kinked structures. That delicate balance is the important part. Trans fats are absolutely awful, though. They're rigid, artificial, unsaturated fats that do not form that kink. Their carbon-carbon bonds are in a trans form, which means they still remain in that straight line formation. And they essentially mimic saturated fats. Both of these structures, when you take them in excess, are going to pack very tightly in cell membranes and decrease the fluidity of the cell membrane and physically slow down all of those enzymes and proteins we have in our cell membrane, including the insulin receptor, our glucose transporters, but other things as well. And most saturated fats in this straight line, because they pack so tightly together, they're solids at room temperature. You can think about butter. So you can think of this as too much saturated fats or trans fats will make your cell membranes more like the consistency of butter rather than vegetable oil. So hopefully that makes sense, that if your cell membranes are like butter, they're going to be very stiff and not fluid. The major issue with trans fats, though, versus saturated fats is that they're artificial. They actually are not naturally metabolized by our body due to that trans double bond. And these fats, when in excess, can start to become inflammatory because they have to be broken down, and it's usually mediated by fatty acid oxidation. And remember when we talked about oxidation and reactive oxygen species, it's nice when we're using benzoyl peroxide to create free radicals that kill bacteria, but those same oxidative, that oxidative stress on our normal cell membranes is probably not so good, which can trigger the cells, those butter-rich, thick cells are like, oh my gosh, something's not right here. Let's start sending inflammatory flags out that something's wrong with us. And then that will spark our immune system like we've learned before. Now, if this happens a couple times, fine. But cumulatively over your life, it can create a lot of damage, which is why diabetics and metabolic issues tend to increase the risk of cancer, right? Obesity is a large or a giant risk factor for getting cancer. It's that oxidative stress. So these fats behave less like nutrients, and especially trans fats, and more like metabolic toxins. And then the fats that we need to eat in combination with saturated fats in a good ratio are the unsaturated fats that are in the cis double bond to form those kinks, which keep the fats from packing too tightly together, increasing cell membrane fluidity. So you can see, a viscous cell membrane is going to be much thicker like butter rather than a fluid one with these kinks. And a lot of people don't think about fats and diabetes and metabolic syndrome, but because they say, well, fats don't raise glucose levels, so it must be fine. It must not have any fat, factor in this. Well, and that's true. Fats don't spike glucose, but it impairs the body's ability to respond to insulin. Because think about an insulin receptor sitting in this cell membrane. Once it connects to insulin, is it going to be able to travel through that cell membrane easily and start the signaling in the cell? No. It's physically a barrier to proper insulin. And then we have our proteins, that last nutrient, which are always essentially broken down into one of our 20 amino acids. And if you remember from molecular biology, you might remember that we have 20 amino acids, which can build up all of the different proteins in our body. How many proteins do we have? All of our clotting factors, all of our insulin receptors, all of our G protein linked receptors, all of the metabolic machinery that causes, mitosis, all of those are proteins. Enzymes. We have the essential ones and the non-essential ones. And you might ask, how can proteins, which we think of something that is generally healthy, contribute to insulin resistance? And this actually specifically has to do with certain amino acids, isoleucine, leucine, and valine. These three amino acids are known as branched chain amino acids, and they serve not only to build the proteins and the building blocks that we have in all of our different proteins, but they're also really potent nutrient signals in the body. They basically signify or tell the body that we have just had a nutrient abundance. So they're chemical signals as well. And they signal to muscle tissue that it's time to grow. These branched chain amino acids, also known as BCAAs, we find these in a lot of things, like processed meats and protein supplements, like whey protein, things like that. And that might make sense, if you're using it, as part of your health, because you go to the gym and you take protein powder, it's going to signal to your muscles to grow. That's all great. But if you're over consuming these protein supplements or processed meats in combination with the other issues, then they actually become damaging. Remember, all of our cells live in a state of either storing energy or using energy. You can't have your cake and eat it too, if that makes sense. And so if we're flooding our bodies consistently with high ratios of BCAAs, it's going to signal muscle and cells in our body to use energy rather than to store them, potentially promoting downregulation of insulin receptors. Because what we'll find is insulin is our major energy storage molecule. It tells all of our cells and our fat, our muscle, our liver, or whatever, to uptake glucose and store it. And so if you're using energy, it will decrease the amount of insulin receptors because we're not storing energy, we're using it. And so now when you think about the different nutrients involved in metabolic syndrome and diabetes and prediabetes, the worst combination are going to be high fat, refined carbs, and BCAA-rich protein. This combo essentially is going to maximize insulin resistance by downregulating receptors while demanding high insulin output by your pancreas and beta cell stress. These are things like pizza, burger, fries, fried chicken, donuts, ice cream. I know. I shed a tear while I was making this lecture. It's funny. We were watching, I don't watch sports at all, but I would get into sports highlights because I think they're cool. And me and my wife were on the couch the other night watching just sports highlights, and there was this guy running to catch a baseball, and he jumps up really high and goes over the back wall and catches it and then falls over the back wall, and I'm just sitting there with potato chips yeah, I knew he could get that. Oh, he could have totally got that. So, now that we have the nutrient side of things in our mind, let's look at the endocrine pathways that are involved with regard to insulin and energy storage. And here we have our pancreas, our liver, our fat, our muscle, and all of the organs will have insulin receptors on them, okay, on their cell surface. And after we eat, we're going to expect that glucose levels in the blood are going to increase. So let's look at the reaction of the pancreas in response to elevated levels of blood glucose. And in the pancreas, we have specific cells known as the pancreatic beta cells located in the islets of Langerhans. And in this cell, we have a glucose transporter 2 enzyme. We have some potassium channels, a voltage-gated calcium channel, and other receptors, which we'll get to here in a bit. What happens is circulating glucose is going to be uptook by the glucose transporter 2 protein, which is going to pump glucose into the cell. This glucose is going to be converted into glucose 6-phosphate by glucokinase enzymes. And this will then go through the Krebs cycle or the citric acid cycle or things you've learned before, and it's going to be eventually converted into ATP, right? And that has to do with the citric acid cycle as well as these ATP molecules being created through oxidative phosphorylation in the electron transport chain. This is why we have to breathe oxygen. And then side products of combustion is always going to leave behind a little bit of CO2 and water. And it's important to note at this time that this GLUT2 transporter has a very high Km value, which from chemistry means that it easily binds to and moves glucose into the cell. Its Km value is like 15 to 20 millimolar. And therefore it has really low affinity for glucose, but it's very sensitive to it. Some other glucose transporters that we'll talk about here in a bit, like GLUT4 or whatever, 1, 3, those are going to have a very low Km and therefore a higher affinity to glucose. And this high Km makes it more so that the islet cells can allow for glucose sensing. They're basically glucose sensors. They're little sensors that stick out into the bloodstream and they'll measure the amount of glucose in the blood. And the rate of entry of glucose into the beta cell is going to be directly proportional to whatever the blood glucose levels are. Furthermore, this potassium channel here is always open, constantly pumping out potassium from the cell. One thing I want you to recognize and kind of put in your brains now is, where does most of our sodium live in our body, for example? Extracellularly, outside of the cells. Where does most of our potassium live? Inside of the cells. This is why when you look at a basic metabolic panel, sodium is usually around 145 and potassium is usually around 4.5, much higher, because when we're taking a blood sample, we're taking extracellular levels. So this potassium channel is always open. And with this potassium channel always open, it's going to constantly be moving potassium from the inside of the cell to the outside, naturally, right? Because most of our potassium's in the cell, so it's going to want to flow down its concentration gradient from an area of high concentration in the cell to an area of low concentration outside the cell. But only kind of in this specific area of the cell membrane. So with this movement of potassium from the inside to the outside, this is going to create a small bubble of negative charge on the inside and positive charge on the outside. And that's because we're moving a positive charge from the inside to the outside. So if we move that charge, that means this outside is going to be a little bit more positive and this inside is going to be a little bit more negative. And that's just constantly happening. It's creating a membrane potential difference, like a battery. But when our ATP production in the cell is increased due to increased glucose, it's going to block that potassium channel, and it will end up closing it. I made these. What's that going to do? Well, that's going to stop the movement of potassium from the inside to the outside, and it's going to completely break down this concentration gradient in this membrane potential that was happening. That means it's going to signal to a voltage-gated calcium channel. Voltage gating means that it's sensitive to voltage. So it noticed that there was a membrane potential there before, and now it notices that the membrane potential depolarized. Depolarized means it went from polar negative, positive on one side to nothing, 0. And that's going to trigger the opening of our voltage-gated calcium channel with a huge influx of calcium into the cell. And one thing I want you to put into your brain now is calcium is the great doer of the body, right? It makes things happen. When you were talking about muscle contraction, what was the thing that, caused our muscles to contract? Release of calcium from the sarcoplasmic reticulum, right? Calcium is the main doer of the body. And when calcium is pushed into the cell, it's going to induce vesicles filled with insulin to exocytose and release insulin into the blood, or interstitial space first, but then into the blood. You can see that we also have other receptors over here. And we'll learn that muscarinic receptors from the parasympathetic nervous system and beta 2 receptors from the sympathetic nervous system can also have effects on these beta cells. More importantly, that I want you to see right now, though, is this receptor here. This receptor, or GLP-1, is extremely important, and it's known as the glucagon-like peptide 1, or sometimes interchangeably the gastric inhibitory peptide receptor, which we'll talk about more. And when activated, these receptors can increase the levels of cyclic adenosine monophosphate, cyclic AMP. And this chemical is this chemical calcium? It's not, right? It's not calcium. It's cyclic AMP. And the interesting thing about this molecule is that it will not induce insulin release. All it does is amplify insulin that's already being released. So you have to have this entire pathway of calcium in order to cause insulin release. If you don't have the calcium, you could make as much cyclic AMP as you want. Nothing's going to happen. But if calcium's already there, this is only going to amplify. So instead of, let's say 4 insulins being released from calcium, if you have cyclic AMP2, now it'll release 8. So it's just amplifying what's already there. You can see that I drew our little insulins here as 2 red rectangles with 2 small little links between them. And that's because insulin is 2 proteins of amino acids linked by a sulfide bridge. We know mRNA code for proinsulin, and proinsulin is this long, continuous strain of amino acids, and it's created by ribosomes. What happens is proinsulin goes through the endoplasmic reticulum when it's being created, where the C-peptide gets cleaved off and gets packaged into vesicles by the Golgi apparatus. You can see that enzymes usually come in and they cleave the spot here at this blue mark and here. And so you can see how this extra piece is cleaved off and it looks like a C. That's why it's called a C-peptide, which leaves behind this strand of amino acids and this strand of amino acids linked by a sulfide bridge. And the C-peptide's interesting because sometimes it's really hard to differentiate between type 1 and type 2 diabetes. Is the patient making insulin or are they not making insulin? And one way you can figure that out is ordering a C-peptide. If a patient has elevated levels of C-peptide, they're making insulin. If they have no C-peptide, they're not making insulin. So that's a good way to kind of track somebody, because sometimes type 2 diabetes can transition into type 1 because all of those beta cells are chronically stressed over time and they start dying off. Once this new insulin is created, usually it's also attracted to positive zinc ions that we intake in our bodies. And they form these hexameric complexes that can be stored as kind of depot preparations too, which we'll talk about here in a bit. I brought up GLP-1 as a molecule that increases cyclic AMP and amplifies insulin secretion. But I want to take a moment to discuss the importance of these proteins because 5 years ago, we weren't teaching this. This is how new and important these things are. What you'll learn is that GLP-1 and GIP are both incretins that are naturally secreted by the body in response to food. The goal of the body is to, when you intake food, to secrete large amounts of insulin before all the food hits your bloodstream, right? Your body wants to be proactive, not reactive. And these incretins are the things that sort of do that. So the goal is to tell the body and the pancreas that nutrients were just consumed even before the nutrients hit the bloodstream, to amplify that insulin secretion before it hits the blood so that sugar spikes don't occur, because as we'll find out, hyperglycemia is very damaging. GLP-1 also slows down gastric emptying, and it does this because slowing down the gut will prevent a further spike in absorption of blood sugar. And GLP also goes through the blood and tells the hypothalamus in our brain that we're full, and it decreases appetite and increases satiety, or like that, or go to a Chinese restaurant and eat too much, it's like, ugh. But what we'll find is that our body's GLP production has a half-life of only about a couple of minutes, as it's broken down by an enzyme known as DPP4, dipeptidyl dipeptidase 4. GIP is similar in the sense that it's also an incretin, and it's secreted by K cells in the duodenum and the jejunum. It's also increased in response to nutrient abundance and does many of the same things as GLP-1, but it does not slow down gastric emptying. But it is broken down by that same DPP4 enzyme. And to kind of better view that action of these gut hormones, we'll go back to our pancreatic beta cell. You can see both of these hormones work to amplify insulin secretion. But after they've had their action, they can't just stay around forever. So they're quickly broken down by DPP4 into inactive metabolites. Another thing I want to bring up that's a very important point with insulin is once it's secreted by the pancreas, it doesn't just go into the systemic circulation right away. So we know the pancreas is part of our gut, right? Where does everything, all of the blood in our gut lead to? The liver. So the portal venous system, right? Which goes to the liver first. And so once the pancreas secretes insulin, it's going to go to the liver before it ever has a chance to get into the systemic circulation. And this slide shows that when we intake glucose into our small intestine and nutrients from our diet, and this will also include GLP-1 that were secreted by those jejunal cells and stuff, then our pancreas is going to sense that glucose and secrete insulin as well, all in the same system. And so insulin and glucose and anything that gets absorbed must go through the liver before it ever gets a chance to make it to the systemic circulation. And as you can see here, only about 50% of the insulin that we make actually makes it into the bloodstream. The other 50% goes and gets completely metabolized and broken down by the liver. So you can think of our insulin that we make has a bioavailability of only about 50% by design. But then once it gets past the liver, insulin will make it into the circulation and have its effects on all the other organs, which actually does include the liver as well. What we'll find is the kidney will pretty much clear the remaining insulin that's in our bloodstream. But, and this is just kind of a mental note for the future, when we use injectable insulin, we bypass this system. So that is kind of a one step up when we get to that point. Once insulin makes it to the systemic circulation, it still only has about a half-life of 3 to 5 minutes. So it doesn't live very long. One of the reasons why we don't just test insulin levels, we test C-peptide levels, because it's going to be very difficult. So the first organ that I want to discuss how insulin has an effect on is the liver. So what happens when insulin attaches to insulin receptors on the liver? And let's first look to see what the normal mechanism is. And so this is a zoomed in view of a hepatocyte in the liver. And blood glucose and insulin are arriving in the liver, we'll say, at the same time. Well, the liver cells also have glucose receptors, the same ones we found in the pancreas. In addition, we can see an insulin receptor here. And insulin receptors have an alpha subunit, which is linked to an internal tyrosine kinase, which is that beta subunit. Not terribly important that you remember that part, but it is what it is. And we learned that GLUT2 receptors have a high Km. So glucose is going to easily pass into the hepatocyte. And when insulin binds to the receptor, phosphorylation of proteins, including other kinases, lead to an immediate response, which is activation of glucose metabolism. This metabolism is going to lead to the production of ATP, as we saw before in the pancreas, from the citric acid cycle and the electron transport chain. But also, there's going to be a storage of glucose in the liver, known as glycogen, and then a conversion of some of that to fats. And we store about 100 grams of glycogen within the liver normally. We also have delayed effects that can occur. And the first is increasing the amount of amino acid uptake for protein synthesis, like needing new GLUT receptors or insulin receptors and all the different proteins that our liver makes, clotting factors. The liver is probably the biggest producer of enzymes and proteins in our entire body, like those CYP enzymes or whatever. Furthermore, because our liver recognizes that we have enough glucose in the bloodstream from our diet, it's going to turn down de novo synthesis of glucose. And this is an important point. We think that all of our glucose comes from our diet, right? But our liver has the ability to synthesize glucose in certain fats and proteins on its own. Most of that actually occurs at nighttime when we're sleeping, which is the reason why blood sugar tends to spike really high during the night for diabetic patients, because our liver can create sugar on its own. It's also going to decrease the breakdown of fats into energy and ketosis and protein catabolism. And if you've never heard of catabolism, it just means breakdown. We know people like to take anabolic steroids to build up muscle, but catabolic means breakdown. And this makes sense. We have enough nutrients. Why would our liver need to make glucose? Why would it need to break down fats into energy? Why would it need to break down proteins into energy? We have enough energy from our diet. So it makes sense why it's going to turn down all these things. And once these processes are done, the insulin receptor usually gets internalized by the cell and it's destroyed. But what happens to our body when these receptors are overstimulated? Those insulin receptors are going to downregulate. And so what we find is excessive overactivation of insulin receptors is going to lead to their downregulation, and it's going to impair metabolism and cause fat accumulation and things like that. And recognize that having the GLUT receptors means that glycolysis in the liver is going to be limited by blood glucose concentrations. And I also want you to just, for the future, kind of compare and contrast these mechanisms when we look at adipose and muscle. Yeah.
So when somebody's insulin resistant, they're like downregulating their insulin receptors. Does that mean you're having inappropriate gluconeogenesis?
Yes. Mm-hmm. So yeah, that's a great question. So if we have downregulation of insulin receptors, glucose is still, at least with GLUT2 receptors, it's still going to come into the liver cell, right? It's still going to make it in here, but it's just going to sit there because those insulin receptors are going to tell it to be stored as glycogen or burned for ATP. So if we don't have the insulin receptors, your liver cell is going to be like, we don't have any glucose, even though it is there. They can't do anything with it, right? So it's going to be like, oh my gosh, we don't have glucose. Start making it. Start making it on our own and send it out into the bloodstream, which is going to amplify the hyperglycemia component. And then it's going to start burning fats instead. It's going to go into ketosis, fatty acid ketosis, or protein breakdown, and things like that. So what about insulin effects on adipose tissue or muscle tissue? Well, nicely enough, the mechanism in adipose and muscle are pretty much the same. They're very different than what we find in the pancreas and liver, but these two have similar mechanisms to each other. And you can see that the major glucose transporters that we find in muscle and fat are the GLUT4 And, well, we have some fatty acid transporters too, but those aren't as important. We're focused on GLUT4. And these transporters have to be signaled to move to the cell membrane rather than just being already present, as we saw in the pancreas and liver. And also what we find with GLUT4 is it has a really low Km, only about 5. And this means that it has a very, very high affinity to glucose. So it's going to suck up any glucose that it comes into contact with. And therefore, GLUT4 receptors are not acting as sensors, like we saw in the pancreas and liver. They're acting as, let's move as much glucose into the muscle and adipose tissue as we possibly can. They're not sensing anything. And this mechanism starts out with insulin binding to insulin receptors, which is going to signal the movement of vesicles filled with GLUT4 receptors to attach to the cell membrane. And a lot of times these signals have to do a lot with calcium too. Calcium being the great doer of things. GLUT4, once on the cell membrane, is going to pump glucose into the cell. And this enzyme is the rate-limiting step of glucose uptake by adipose and fat. But again, having glucose in the cell means nothing if insulin isn't there to promote the immediate effects of using the glucose for ATP production or storing it as glycogen and fat. And in muscle, we store about 400 grams of glycogen. And therefore, insulin in muscle or insulin in fat is going to promote storage. So it's going to decrease the amount of like free fatty acids in the blood or glucose in the blood. In storage, let's say we're storing it into fat. What does that mean? Well, insulin being the great storage molecule means that insulin itself can actually cause weight gain because it's storing everything. But just like the liver, what happens when we overactivate these insulin receptors? Well, let's say we have a case where we have hyperinsulinemia and chronic overactivation of receptors. Well, those receptors are going to downregulate. You see how I made them go away? Wait, I want to show you again. Took a long time to figure this out. So they're going to downregulate. So instead of having 4, let's say we only have 1 now. And anytime we downregulate receptors, it's going to be perceived as a decrease in efficacy, right? And so that insulin signal is going to be drastically reduced. Leading to decreased amounts of GLUT4 proteins in the cell membrane. And this is going to completely break down the ability to intake glucose into cells and burn them for ATP, for muscle, right? Or store it as glycogen or fat. And so the end result is going to be sugar is going to stay in the bloodstream, and the pancreas is going to increase insulin production. And so we're going to have hyperglycemia and hyperinsulinemia as the pancreas is overworking or working overtime to try to handle that elevated blood glucose. And these muscle cells are going to starve of energy. And so they're going to switch to ketosis, where they're going to use fats for energy or protein for energy, and you'll get muscle breakdown because they're just trying to stay alive at this moment. It's kind of sad. So now that we've kind of reviewed the cause of diabetes and the mechanisms of diabetes, type 2 mainly, what's the result of having too much sugar in the blood then? Well, that elevated blood sugar is going to lead to organ damage, to that 8-organ model that I was talking about earlier. And whether we're talking about type 1 or type 2 diabetes, or all of the other types in between, the end organ damage that we find is all going to be the same. And I've also come up with my own definition of how this happens. And I want you to think of elevated blood sugar causing damage in 2 ways. Acutely or quickly, and chronically or over the long term. Acutely, what we'll find is that large glucose molecules act as an osmotic agent. And chronically, blood sugar can react with proteins all over the body to form irreversible covalent bonds with them, similar to the reactive oxygen species doing damage to cells that we talked about before. And damage to cells, no matter what cell it is, we learned causes oxidative stress and damage, leading to chronic inflammatory responses that result. Even if they're low level, it's still chronic inflammation. And I want to first kind of look at the acute stuff first, the stuff that happens quickly, which is the osmotic and electrolyte disturbances that we see. And we've seen this slide before, although I still don't know if this is correct or not. Is that correct? No. I just copied and pasted, so it's... We know that at the glomerulus, we have pores with a basement membrane that allow for lots of stuff to pass through into the urine, including glucose. And in the proximal convoluted tubule, there is an area of the nephron that we reabsorb about 65% of all of our water, sodium, chloride, potassium, calcium, etc., as well as 90% of our bicarbonate. What's bicarbonate in our body do? Acid-base balance, right? I remember in inorganic chemistry, we had a big tub of bicarbonate, sodium bicarbonate. So if somebody spilled an acid or a base, you could just dump that on it, and it's a neutralizer. So bicarb is the great neutralizer of the body to bring our pH balance back into range. And this is also where we reabsorb 100% of all of our amino acids, 100% of all of our glucose, and 100% of all of our proteins like albumin and whatever. We also, yes?
So when you said earlier that if you produce too much insulin, your kidneys take care of it, how do they take care of it if you reabsorb 100% of the proteins in the body?
We have specific, so we learned that CYP enzymes live in our liver, right? But I also said there were a bunch of like other organs that can have CYP enzymes in them, including the kidney. They're usually broken down by the CYP enzymes. We also saw that this is where those active transporters of drugs out from the blood into the urine occur in the opposite direction, because we learned that those are where the xenobiotic active transporters were. But in this case, we also have other enzymes here that pump things in the other direction. And these enzymes that are on the luminal side, luminal means lumen, which means tube, so the urine tract. On the luminal side of the cell membrane, most of these enzymes here are the transporters that transport glucose and amino acids and our bicarb and all those things from the urine back into the blood. So the proximal convoluted tubule is an active energy user for sure. Does a lot of good work. And although we don't have a ton of enzymes on the luminal side of the cell membranes of our PCT, there are specific proteins used, and we're going to look at just glucose in this case. And this enzyme that we see that lives on this side is known as the sodium glucose cotransporter type 2, or SGLT2 enzyme. Let's take a zoom in on that transporter. And so this is the same slide, but blown up to just one nephron cell, okay, one renal cell. And one thing I also want you to note now and for the future of forever is that every single cell in our body has an engine on it known as the sodium potassium ATPase. Have you heard of this before? So again, most of our sodium lives on the outside, and most of our potassium live on the inside of cells. And that one of the major proteins that makes that happen is our sodium potassium ATPase, which constantly pumps sodium out of the cell and constantly pumps potassium into the cell by using ATP for energy to do that. Okay? Which creates gradients of high sodium outside, high potassium inside. And with low sodium on the inside, that means that other enzymes can use those gradients to their use those in their advantage. It can use that gradient to your advantage. And that's exactly what the SGLT2 enzyme does, especially from sodium in the urine. what it'll do is it'll use that sodium gradient to pump in sodium. At the same time, it'll also pump in a glucose in at the same time, which goes through a similar GLUT2 receptor we saw in the liver and pancreas to get the glucose back into our bloodstream, right? Remember, our bodies are designed to starve. They're not designed to get rid of things. So these enzymes are here in order to recoup any glucose that was lost, which is kind of nice in a normal person, right? But what happens if somebody has hyperglycemia and now they're dumping a ton of glucose into the urine that was filtered through the glomerulus? Well, those SGLT2 enzymes are going to reabsorb as much glucose as they possibly can, but they won't be able to keep up. And this means a lot of glucose is going to stay in the urine. And glucose is a large osmotic molecule. And what that means is water likes to follow it. Sodium is actually usually the ion in our body that water likes to follow, which is why when you eat Pizza Hut, like a bunch of pizza from Pizza Hut, a day or two after, your rings have a tough time coming off because you ate a bunch of sodium and now your body's holding on to a lot of fluid, which moves into your interstitial space. But with glucose being trapped in the urine, water is going to follow it, leading to increased dilute urine production with large amounts of glucose and water loss. This also leads to sodium loss, potassium loss, and bicarb loss, right? Because that's where a lot of those other things were reabsorbed too. What happens if we lose a lot of bicarb? It's going to be acidic, right? Your blood is going to be acidic behind. And these electrolyte losses and water losses lead to the main symptoms of the polyuria, increased urine production, polydipsia, increased thirst, dehydration, acute kidney injury from dehydration, confusion, in severe cases, diabetic ketoacidosis or hyperosmolar hyperglycemic state, which we'll talk about, because there are two differences that are really important to distinguish between these two things. Let's go ahead and take a break. Is this making sense so far? Cool. No. So they easily kind of move things across.
Don't go down on them.
What happens is you know
So basically, like your body just first.
what happens there is just let's just go and trying to like,
And then all this extra insulin is
and that's how they sense.
Okay.
The more glucose that they go in, the more they sense. It would probably be better.
Oh, I do have like
Teacher diabetes better.
I don't know. I heard.
Oh, thank God.
We're going through the mechanisms from start to finish on how diabetes works. Everything from nutrients that we take all the way to
Oh, there's nothing on that screen.
nope.
What is on the other screen?
We're sleeping here.
Let's talk Tortle today.
Okay, but what's the question?
Should I use to
We're
raise
sleeping.
my
Okay, does she have any history of mental health stuff?
Okay, well, we don't ask questions.
well, mom
Oh.
says fats?
Maybe just insomnia.
Here we go.
Oh, I already know it.
Is
Processed
it after the second one?
Intense.
Nope. It's the first one, and I already know it.
Oh, you know it because of it. I'm gonna say it after you answer it. You know it because
Wow.
of the age.
They give you literally almost. They give you 0.4 off the median age.
Win
Yeah.
rate? What's your win rate?
Uh,
Dr. Rose is 89%.
I don't know. I usually do it when I'm
51-year-old with irritability and mood issues, menopause.
I did MDD first. After the second one, it was obvious. The second one was flushing. Second one was super obvious.
How did everybody do on their first exam?
Pretty good.
Big.
Pretty good.
Senya's dad just talked to us about nephrology. He's so knowledgeable.
Yeah. I want that lecture.
Can I see your
What, the
slides?
nephro one?
Oh, you know what Cindy and I were talking about? So Ninja Nerd has these
Illustrations on his website, and you can like watch one of his YouTube videos and fill it in as he goes. And I was thinking that for certain things, like especially your first lecture where you talk about partial and full diagonals, I thought that that might be good to have like, but you would have to color code it so that your underlined sections are always the same, or so that whatever they're drawing on their iPads are there.
Not a bad idea. Sounds like a lot of work.
I mean, it's a
Yeah.
pretty simple
Well, actually, it's just blank.
concept, though. You know what I mean?
If you already have illustrations that pop up in order to do the same thing.
Yeah. Fair enough.
Yeah. It's not like he's just putting words on the slide.
So how was nephrology?
I mean, it was good. It's interesting. It's just like he started talking about like hyperkalemia and hyponatremia more, and we just went over that yesterday, and my brain is just like,
The
I
guy
can't.
yesterday explained it perfectly.
yeah. He
It
put
was like
he talked about hypovolemic states, euvolemic states, and hypervolemic states, and how that relates to hyponatremia, and how it's not like true
I really just see
hyponatremia.
the picture in my head now, and I
Yeah.
know the treatment. It's funny. He did these bar graphs. He's like, the paradigm shift you have to have is thinking of total body sodium as your volume status and not your total body water. So
Yeah.
then when you mash it up, you're like, oh, they're hypervolemic. So we need to diurese because their sodium and their water's high, versus euvolemic where you need to fluid restrict because sodium's normal but water's high. But it's cool.
Did they record those lectures?
No, I don't think so.
They just texted me to ask me if you want to come say hi, and you guys are already in here.
Oh,
I got dumped.
Senya?
you were talking. Your dad's in there.
What's the barometric pressure today?
It's fine. I feel great.
It's currently
My dad
negative.
just gave us a lecture.
Did he record it?
No.
Oh yeah, look at that.
Yeah, it's good.
757 a
Good
day.
stuff. I got acetazolamide.
You did.
Yes. I haven't started it yet. Because I don't like taking it daily.
Senya starts passing out around 7:30.
So we're good.
Oh.
Good. So good.
What's the pressure up there?
It's 7:30 up there.
Oh. It's funny that you have that right on your phone.
Yeah.
I have a question. Berberine, have you heard of it? It's a supplement. It's a CYP inhibitor. And I'm taking it alongside a bunch of drugs that need CYP enzymes.
Just drink grapefruit juice.
Oh, okay.
That's, I wonder what the main ingredient is in it.
In berberine? I don't know.
In what?
Berberine, that's a supplement. that I'm
Berberine.
taking. Yeah.
All I can think of is very, very.
Wow, you sucked at that one.
No.
No.
Oh, he got it in one. It looked like he took all of them.
Oh no.
The question might as well have said she's 51.4 years old. What is it? Menopause. 51.4 is the median age.
How do you even remember that?
I saw it on the slide.
51.4.
I think it's that.
So I forgot. My mom sent me an article. She's like, Cynthia, do you know what kratom is? How can you die from kratom again? Like, what does it do? I don't remember.
Isn't it super addictive and it's very sympathetic-y? So then they take too
It's
much?
like mixing amphetamines and opioids in
I
one.
love that.
Yeah.
Sounds
Do
like
it
a
all the
party.
time.
Yeah.
That's-
you tried it?
I
No.
can't drink, so I take cocaine instead. Did you know that?
Huh?
Muslims, we can't drink, so we do cocaine instead.
Ah.
Apparently, that's what some diabetics do.
Hmm.
What are you guys studying today?
Diabetes?
Oh, you're doing diuretics.
Diabetes?
Diabetes. I taught Christian all about acetazolamide, so when it comes, he read the whole thing. I gave him my sheets. I give him my sheets now. You know, like the one that comes with the drugs. And with like 9.
So I haven't started yet.
Yeah. Why haven't I started it yet?
Where's Christian?
I don't know. I'm scared.
Do it before before rotation.
I forgot that.
You should do it before rotation, see if it helps, so you don't take it and then go to
I forgot
rotation.
that Dr. doesn't cause his
Yeah.
memories.
I also have a 6-hour EEG next week.
Wow.
Yeah. And you can sleep. You have to sleep less than 4 hours at night because they're trying to sleep deprive you. And I'm getting a Holter monitor the first day of rotations. So I talked to Tobias. I'm like, it'll just be during lunch break. I'm gonna go.
Why a
and get
Holter
it.
monitor?
Because Because my doctors. Yeah, we have beef with her. And then she ordered a Seinfeld MRI because I haven't had one since 2020. I just had normal MRIs. And then in my note, she said that me and Tristan were asking for the MRI, but we were not.
Bro, her
She
note
wrote
was so
such a sassy note last time. So I started taking
What did you
it.
grill her?
No, I started taking because like I like freeze because she like stresses me out.
I want to know what symptoms
look cute
she
today.
like quoted Chiari's symptoms, and I want to ask her like what
She says
symptoms,
Chiari's symptoms
do
don't
you
exist.
contribute to Chiari, this patient?
Yeah.
Or
Yep.
if any, because like, and I get that her
A
idea.
neurologist said,
Yeah, she literally
The other
said
thing-
there are no Chiari symptoms. It's just a structural abnormality. And I
Yes,
was
it's
like,
the MRI
I
was
literally
wrong.
have a syrinx, and like everything I have is a typical Chiari symptom. And particularly my dysphagia, she's like, that's just migraine symptom. And I'm like, that is one of the first signs I have
"Oh,
for
it's because
Chiari.
it's pressing on your midbrain."
Yeah.
Went on about like, well,
So it's going to mess with all your autonomic stuff.
But she doesn't believe that. She says it's a headache.
she went on about how she
just
can't
take your
control
time,
the
but
Chiari. There's no medication for Chiari, and that may be true.
nobody can.
But the
Yeah,
way
it's
that
not
you
true.
can communicate that to the patient
just like,
is that
whatever,
well,
as
I
long
want
as
to
you show up at
maximize
some
migraine control as much as possible to prevent any crossover, right? Like it's like there's two levers pulling on your symptoms right now. One of them's Chiari, that's relatively
That makes
fixed.
sense.
But she like did not, and I'm like, I tried to ask her like, what symptoms are you tracking to see if a migraine intervention is effective? Because her meds changed since last visit, but her symptoms haven't. So it's like, what are you tracking to see if the med's working?
What?
I can't.
Well, she says everything is migraine. And she wants me to take 300 milligrams of carbamazepine, 425 acetazolamide, my Aimovig, and a Nurtec every day, and Ubrelvy as needed.
Did
and
the
she gave
Aimovig
me another
help?
triptan. The Aimovig helps with
Okay.
my migraines. And I told her that these days that I pass out, I wake up with it. And it's like really bad when I'm laying down. I sit up in my bed and I like sit there for 15 minutes, and then the pressure decreases in my head. And I'm like, I can tell you 90% I'm gonna faint that day. And I always text him in the morning, pressure in my head. What happens is I faint during that day because I went upstairs or something happened, or I vomited because I was in pain. And she's like, no, that's a migraine. You need a... And then she goes, it's because you have PCOS. She says, patients with PCOS have increased spinal pressure. So she said, my increased pressure is not my Chiari. It's apparently PCOS. And I said, okay. Like, I just lost it. I was just sitting there like, I'm done.
Were you
And
as
then
frustrated with the visit?
he was pretty pissed off too, yeah. I just went silent. I just let Tristan talk.
Yeah, like at one point I was like, okay, say Cindy didn't get a say. Like, what meds are you feeding her? Because I was like, what if, if we take it, it doesn't work. Like, it doesn't work, right? And then she's like forced into thinking that it doesn't, even knowing that it doesn't work. But she was like, basically the carbamazepine, 300. And I'm like, okay, what level do you get fatigued at? And
Why don't you get a second opinion?
This is my third opinion. The other problem is the other one I used to go to Mercy and they give you medications for side effects instead of stopping. I was on amitriptyline forever and I was tacky like crazy and he put me on metoprolol, which made me even more tacky because I kept bottoming out and I kept passing out. And then he tells me that you never get tacky on amitriptyline, it's just anxiety. And I was like, okay. And then I stopped it without telling him, got better. And then he just throws prednisone at me all the time. Here's a prednisone taper once a month. And then I begged for the Aimovig. So then now I'm at ProMedica. For
Do a
this.
VP shot.
I don't want to. I'm terrified. And I literally haven't felt my legs since I got a stent place. So there's just a lot of scary, like the thought of a shot. Like if I woke up and I haven't felt this leg since. The thought of a shot is like, okay, what if I like get paralyzed? I don't know. Yeah, we have to go. Sorry.
Oh, yeah, okay. Yeah, I gotta get started.
Yeah, you have class too.
See ya. All right. So there's big differences between DKA and HHS. And they're pretty important. So type 1 diabetics, so they lost their ability to create insulin. So there's no insulin being secreted, and therefore no GLUT4 receptors are going to be located in muscle or adipose tissue, and no insulin-induced storage or glycolysis is going to occur in the muscle, liver, or adipose tissue. So not only will the dehydration and osmotic diuresis, or peeing out all the water you have, occur, as well as those electrolyte abnormalities and bicarb loss. But now the body essentially is going to have zero ability to use glucose for energy. And so the body only has two other molecules to use for energy, fat and protein. Fatty acid oxidation is what occurs when you break down fats for energy. And the term fatty acid has acid in the name. So when you break down fats, you're probably going to have increased acid production in the body. And then oxidation also leads to oxidative stress. And usually there are ketone byproducts as well. In addition, we lost all that bicarb in the urine. So not only did we lose our neutralizer, but we're creating acid. And so we'll expect that in patients with zero insulin production, that it's going to lead to acidosis. And in an attempt to decrease the acid, your breathing is going to increase, right? To try to blow off CO2. And so these patients are going to have increased respiration. They're going to have keto from the ketones, acidosis, loss of sodium, potassium salts, potassium depletion, vomiting. Their pH is going to become acidic again, leading to hyperventilation, and then eventual hyperosmolar dehydration, meaning they're losing a bunch of glucose and water, which is going to leave all those solutes and everything behind, and so it's going to be hyperosmolar, hypertonic, eventually leading to shock coma death, like everything. And this DKA is very dangerous. In type 2 diabetics, we can have hyperglycemia, but we still have insulin production. It's just resistant. And this means that patients will still have some of those GLUT enzymes and glycolysis production, just not enough of it. And so the body will still be able to use glucose somewhat. So fatty acid oxidation doesn't occur as much as you would see as compared to a type 1 diabetic. But the diuresis does still occur, leading to concentrated sodium and dehydration, similar to type 1. And when this is in the extreme, it leads to hyperosmolar, hyperglycemic state. It's like DKA, not as severe, well, until it becomes really severe. Then it's very dangerous. And this can lead to confusion, soft blood pressures, coma death. Now that we've kind of looked at the acute things that can happen, the quick things that can happen with hyperglycemia, then we learn about the long-term cumulative damage of diabetes. And the major thing is the glycation of proteins. Glucose is chemically reactive. And when blood glucose stays elevated for any extended period of time, it starts to stick to things it was never meant to stick to. And that sticking that occurs is called glycation. And this is non-enzymatic. It's not regulated and it's not purposeful. It just happens. It's, I was thinking about it. It's like chemical vandalism. Most glucose in the body is in a ring form, but a small fraction of it can constantly flip into a linear aldehyde form, which is seen here at the bottom, that's COH. And that aldehyde is actually very reactive. And when this linear aldehyde glucose enters or encounters a protein of any kind, especially ones with exposed amino groups, like any protein in the body, remember proteins are amino acids, it can spontaneously bind to it. And this binding forms what's called a labile shift base, which is reversible, but it can become non-reversible. Proteins are all over our bodies. There are proteins, there are enzymes, they're the things that cause DNA replication, all these things. And glucose can naturally form to that. Things include our hemoglobin, our LDLs, our collagens, our fibronectins, our crystallins, all of the different things. And I mark hemoglobin because it's an important lab test that we'll learn about. Over time, that labile shift base can actually rearrange into what's known as a stable Amadori product. And this step is slow, and it's where the damage becomes irreversible. That glucose essentially will form a covalent bond with the protein. Are covalent bonds pretty strong? About as strong as you can get. This means that it will stay bound to the protein that it attacked. If it's the microvasculature of the eye, it can cause retinopathy. If it's in the collagen or connective tissues or basement membranes, it can lead to microvascular disease like nephropathy, neuropathy, as well as macrovascular places like our coronary arteries, leading to coronary atherosclerosis. If it attacks DNA or DNA polymerase or any of our mechanisms inside the cell, it can lead to mutation and cancer. If it attaches to a hemoglobin protein, this is where we get our testing of the what's called the hemoglobin A1C, or the glycohemoglobin is another name for it. And we measure this and we measure it every 3 months, A1C, because how long do our red blood cells live for? Yeah, roundish about 3 to 4 months. And so it is a direct measure of how many things are getting glycated in your body. So we take a blood sample, we measure the hemoglobin A1C, which is the glucose attached to your hemoglobin. And if it's less than 7, we're cool. If it's greater than 7, you got diabetes, it's getting rough. If it's greater than 10, it's a very poor amount of hyperglycemia that's going on. Have you guys heard of the A1C? This is where it comes from. It's the glycation. So glycation doesn't just mark proteins. It does. It's chemical vandalism. But it also changes their physical behavior, because anytime in biology you change structure, you change function. So the proteins will become stiff. They'll lose elasticity. They'll cross-link abnormally. They'll become resistant to degradation. And all of this is going to lead to that chronic structural damage that we see organ by organ over a long period of time, where we get like Charcot's foot or arthropathy, retinopathy, nerve damage, kidney damage, increased risk of heart attacks and strokes and wounds that just don't heal because of the damage to the connective tissue. Does that make sense? So it's glycation.